you make the clinical decision to adjust the joint, do any type of soft tissue work, whether it be ART, acupuncture, grafts, and when you, or is your first go to the clinical aspect as far as doing it?
How many chiropractors or chiropractor students here? All right, so you're not alone. That's a good question. Ken? Okay. If you go back to the notes, the first section that we went over yesterday, you'll see the on page 7, the clinical approach, as you asked. Our goal is to assess functional capacity. And if there is a functional capacity shortfall, if there is a functional capacity deficit, and it is for you as a clinician to choose your evaluations. I have argued yesterday, from Yonda and Gray Cook's perspective in particular, that we should not limit our functional assessment to evaluation of x-rays or imaging and structural pathologies. Professor McGill is at the forefront in telling us that ship has sailed, and that we know due to the very high, enormous high false positive rate in asymptomatic people, that we need to couple our structural evaluation with a functional evaluation. And now we know also that that evaluation should be an evaluation, as McGill calls it, of motor patterns, as Professor Yonda called it, of movement patterns, as Gray Cook calls it, a movement. And this is not an evaluation of isolated impairments, like just range of motion or strength. It's more of coordination. It's of the ABCs, agility, balance, coordination. But our tests of that will evolve. Our ability in the clinic to emulate what is happening in laboratories like Cholowicki's laboratory at Yale when he was there is only going to expand as we develop new tools that are reliable and valid to assess important things. Where's Thomas? Thomas was talking yesterday about ground reaction time. Very hard to measure ground reaction time. We saw yesterday in our final patient looking at jumping that we could listen, we could be a blind practitioner, and we could evaluate poor motor control and how a person lands, how much time they spend on the ground, how poorly they attenuate forces as an index of stability. There are many different ways to screen. I'm simply showing some that I've learned, that I've learned. And there are others out there that you can gather by taking courses at Athletes Performance from Gray Cook, etc. What we want to do is we want to assess functional capacity. And the tools that we use are going to be driven by our identification of a functional capacity shortfall that's relevant for that patient. So that brings in the history. What's relevant for the patient depends upon their past history. What areas are bothering them? What type of injury they have? What sort of activities they've been involved in as far as accumulated stress and strain over a lifetime. Because everybody's going to have adaptation and compensations. And the greater the athlete, the better they are at compensating. But at some point, their compensations are going to come around to bite them. And it's going to limit their career, either the longevity or their performance, et cetera, et cetera. So we want to know how to evaluate function. And we're going to improve in this arena. And when we find a capacity shortfall that's relevant, that relates to them not being stable in something that they need, whether it's the housewife doing groceries or cooking, or it's the mother carrying a baby, or it's the elite athlete having to kick and fight in an MMA environment. It's going to be a different functional capacity that's required. So we need to tailor that. And when we find a shortfall, then we're going to get into treatment. And our treatment goal is going to be to normalize the poor movement pattern that's relevant for the patient. So our screen yesterday of 7 tests, the MAG 7, Magnificent 7, is nice because it applies across the board to a heterogeneous population. It's a springboard. Everybody needs balance, everybody needs good breathing, everybody needs a certain minimum of mobility in the T-spine. Everybody should have some good stability standing on one leg, doing a simple thing such as a squat or a lunge. These are minimum common denominators for everybody, but that's not sufficient. That may be necessary, but it's not sufficient. So I encourage all of you, I exhort all of you to go beyond that That's just a screen. We now need to tailor and customize our exam, and this morning we'll workshop the people who did well on the screen. We started with people who did poorer in our bell curve amongst our class here, but we'll also look at the people who had no zeros and ones, and based on their demands, their challenges, their goals, we'll decide what other things should we screen. And then it's an open system. And again, in a seminar where you just want to learn techniques, that's all well and good. But I want to show you how to think so that you can go on Monday morning and draw from your own reservoir of assessments and take from the seminar that doesn't even exist today and apply that in a bulletproof fashion. So once we have the goal from the person's history and exam and where their capacity shortfall is that's relevant to their challenges and their wants and their desires, then our goal is to improve the stability, improve the performance in that poor, faulty movement pattern. And the way we do that is incredibly simple. And it was taught to us not by Mike Boyle in the joint-by-joint approach or by Craig Cook when they talk about areas that need WD-40 or need to be tacked down. This comes from Prague, from the Prague School of Manual Medicine, where they said there are areas that are tight and there are areas that are inhibited. We have to balance the muscle imbalance on the DVD, and I'll put it up again on the next break for those that want to stay and watch. Yonda was about to discuss the ideas of muscle imbalance that he proposed over 45 years ago. And in a nutshell, we mobilized the stiff areas and we facilitated, stabilized the inhibited weak structures or weak areas. And this is a very simple approach. And what are the tools of the trade? ART, chiropractic adjustments, fascial release for mobilizing stiff areas. Anything that's inhibitory can be used to mobilize the stiff areas, but not as an end in itself, as a means to an end. And the end is to boost relevant functional capacity so that people have a stability margin for error. That's always the goal. So in the end, the movement pattern must improve, so you have to have a functional evaluation. And we have to find the test that's a one, that they just can't do based on the criteria that you establish. Not I establish, that you establish. Where you say, this is the minimum that I expect for this test. Whether it's Sorensen's trunk extensor endurance, or it's the overhead squat, or any test that's out there. Professor McGill advocates the stability shear test. There are so many different tests. You establish your own threshold, and then you decide when to apply it for which population. And then you want to improve that pattern. And there's two ways to improve patterns. One is to mobilize the tight areas, the stiff areas, and the other is to stabilize the weak areas. And when we create that balance in the system, by whatever means, now that person is going to be able to perform at a higher level. So that they have not only stability, but they're going to now, if they're an Olympic weightlifter or they're a sprinter, they're going to be able to actually enhance performance. So there's that continuum, and that's why we're bridging the gap from training to rehab and rehab to training. Because the same tools for pain management and rehab work for performance enhancement and for prevention of injury. Okay. Now obviously in pain management, we need more of a medical hat-on, more of a palliative hat-on. And people that are personal trainers that are working in a field where the person has no pain, they don't have to use a laser, and they don't have to use Grasman or fascial release techniques, and they can get right down to mobilizing and stabilizing. But again, palliative measures, and we're going to talk about inflammation this morning for a few minutes. Inflammation has to be identified, sensitization has to be identified, and the inflamed patient has to be allowed to recover. My aging athletes, my 28-year-old basketball players in the NBA, we need to focus on nutrition with them. They need extra help with recovery.